has convinced us that we need to use citrate regional anticoagulation, and I'm going to discuss some other aspects that are less discussed on this topic. So I've got a few declaration of interest. I should have added that I'm a big fan of citrates as well, but it didn't fit the system. So Alex has shown us that indeed regional citrate anticoagulation was the way to go, and I'm not going to dwell on it any more longer. And then Thomas has also alluded to the fact that he's performed a survey on the practices, and part of this, it's still unpublished, but he's nicely agreed to share the data with me, showed that the regional citrate anticoagulation is widely used in the world. You see the distribution in the planet of the different centers, and the people, you see the percentage, it's a yes-no questions. So the majority of people are convinced that regional citrate anticoagulation increased filter patency. The majority are citing citrate as their favorite anticoagulation, and also a majority considered that RCA is safer than anticoagulation, and therefore it seems like everything's perfect. It's the way to go, everybody likes it, so it's fine. But there are a few issues, of course, with citrate, and as Alex said, you have to be careful when you implement citrate, there can be complication. This is a small observational study that we completed in my center when we were transitioning from heparin to citrate. And so it's not randomized because we were doing exactly what Alex was saying, giving citrate to the patients less at risk of intoxication, whereas we were giving citrate to the others. But simply we were seeing what you expect, some metabolic complication in terms of acidosis, alkalosis, and that's something that's already very well described. We didn't find any much more complication, but what we did find, very, very commonly, 25% of the patient is hypocalcemia. So I think I'm going to discuss a little bit about these issues first. We know that acute kidney injury impacts the metabolism of phosphate and calcium. It leads to hyperphosphatemia, hypocalcemia, and that all leads to an increase in the parathormone. And of course, this is something that is not desirable because that would lead to a resorption of the calcium from the bone reserve. And citrate in there is possibly increasing or worsening this. We have to be careful. So there's small data. I'm not going to show large randomized control trial here, mostly small observational data, but physiological data that can be of interest because they represent what we do at the bedside. So here, it's a small study conducted in Australia, and you see that the first thing when you see the curve, it's a bit busy, I'm sorry, this is the graph from the paper. The patients, the measurement of calcium in the patient that received in citrate were much lower than those who did not. And that's because the author, as you see on the bottom left, were targeting ionized calcium, systemic ionized calcium of 0.8 to 0.1. So of course, when you do citrate, you have to replenish the calcium that's lost in the effluent, and then you have a target. And this target was, in this study, 0.8 to 1.1. So it's not surprising that the patient had low calcium levels during the study. But that translates actually, and they measured in this study, the mean calcium balance. Of course, the plus and the minus, and altogether, all the patient, all the circles, all the patient that received citrate anticoagulation as opposed to heparin had negative calcium balance for the entire duration of the therapy. That means they were losing calcium throughout the therapy. They haven't gone much further in this analysis, but some other author did. This is a study coming from the Netherlands, pretty much the same design, regional anticoagulation, there was low molecular heparin or no anticoagulation. And also they were targeting a calcium substitution with a target range of 0.8 to 1.0 millimoles per liter. The same as the previous study, they found a low a low calcium level in the patient treated with citrate. But here they also found a negative balance for calcium, which was in this study compensated to some degree by the enteral feeding, which was not considered in the previous study. But most importantly, they measured PTH, the parathormone, which of course is the physiological response to hypocalcemia. And as you see here, it was very much higher in the group that received citrate as compared to the group who did not receive anticoagulation. It was high in the nadroparin group at the beginning, perhaps simply because these patients had hypocalcemia related to their AKI, but that's speculation. So hypocalcemia, or protocols that are not substituting to a physiological level, are associated with an increase in PTH. And Marlies Osterman and her group in the UK did a similar study, but this time they stratified the patient into those who had at least one episode of hypocalcemia and those who did not. And she found a difference in the values of PTH. She found that in the group that never experienced hypocalcemia, the PTH was not increased. It only happened when hypocalcemia arrived. Note that in this group, in this center, the target range was above 1.12. So here we're very much higher and at sort of a normal physiological level. And then she went on and did some multivariate analysis and confirmed that, as we all know, hypocalcemia leads to increase of PTH. So that's one thing. The other thing is that, as Alex has shown you, we have a window. When you're targeting, you're giving citrate to decrease the post-filter calcium, therefore leads to anticoagulation. And Alex has shown us that it's no point going much lower than 0.4 of post-filter calcium, because the anticoagulation effect of citrate is on-off. So it's either yes or no. So these authors have tried to evaluate whether a protocol targeting the higher range of the efficient rate of anticoagulation, a target between 0.32 and 0.4 of post-filter calcium, had different effects on the calcium balance compared to lower targets of 0.2 to 0.7. And so indeed, on the right side, you see they did what they wanted to. The group randomized to high citrate had a lower post-filter calcium, and they received more citrate. But most interestingly, the calcium losses were very different. You would expect that, but I mean, this is at least demonstrated in this data. The low citrate regime had a lower calcium loss and a significantly much calcium loss at all the time points, and this translated into a negative balance throughout the entire duration of the study. For the 24 hours, the high citrate regime, so when you target a very low post-filter calcium, you are leading to a negative balance, which wasn't the case when you in the patient that were targeting the range of the spectrum. So at this level, I think what we can say is that the influence of citrate on phosphocalcic metabolism depends on the protocol you use. And I would recommend at this stage, based on this data, that we should be using, and it sort of makes sense, but it hasn't been the case in all centers and all the time, that we should use a physiological systemic calcium at least superior to 1.1 millimoles per liter. And also, when you are designing a protocol, it's not so easy to be so specific with the calcium, but you should aim rather the higher range of the spectrum and try and avoid to give too much citrate and decrease the calcium too much, which doesn't increase the anticoagulation effect. It probably doesn't increase filter lifespan, but leads to negative balance of calcium. So then I'm going to go quite quickly on citrate and inflammation. That's a topic that was really hot maybe 10 or 15 years ago, when there was thoughts that maybe citrate could lead to decreased mortality. Now there's data that really shown that this is not the case. But there are data that shown that there are decreased production of activated complement 5 or elastase inside the filter, and this data from the Netherlands, and also from more recently from Thailand. It's been shown that citrate was associated with lower expression of markers of neutrophils activation or plasminogen activators, so improved fibrinolysis. So it seems like citrate can be more tolerated to some degree, but this has never been shown to be associated with an improvement in systemic inflammation. There was no change in the level of IL-6, IL-8 in another study from the Netherlands, and that's one of the large trials that compared citrate with the regional alternative for anticoagulation. In this study, no difference was found either for IL-6, IL-8, or IL-10. So in general, I think inflammation and citrate, it's not the story here. It might improve the biocompatibility, might decrease complement activation, but we've never found any evidence, as far as I know, that it modified or decreased the systemic inflammation and that never translated into patients-related outcome in any study, except for the very first study that was possibly a chance finding. So I think the message here is that we should use citrate anticoagulation to ensure filter patency. Anticoagulation is to keep the filter. It's the best anticoagulant because it works the best in terms of duration, but it's not a treatment for sepsis. It's not a treatment for something else. And in the few minutes that are left, I'm just going to touch on the nutritional effect of citrate that are probably very forgotten. We tend to forget that we administer citrate. It's a source of energy, and it brings about 3 kilocalories per gram of citrate. For millimoles, it's 0.59 kilocalorie. It's a source of energy that it's metabolized within the Krebs cycle. It goes straight inside the cell. It doesn't need insulin. And it's important because when you administer citrate, it's running for 24, 48, 72 hours. And Alex already showed this figure. The citrate that you infuse inside the circuit to lead to generate the anticoagulation is to some degree removed by the circuit. It's an almost perfect independent circuit system because it's removed by the circuit, but only half of it is removed, depending on the modalities. But the other half returns to the patient. And that's important because it contributes to the acid-base equilibrium, and that's very good, but it also leads to administration of citrate to the patient and all the potential complications that have already been discussed. So the administration of citrate depends on the amount of citrate that enters the circuit, which is proportional to the dose of citrate you dial on your CRT machine, of course of the blood flow, because these two variables are coupled, and also of the amount that you remove at the level of your filter. So there's not many data, clinical data, really trying to quantify the systemic delivery of citrate and its effect on the nutritional effect. There's this paper from the Czech Republic, Martin Balik. This is a bit more than 10 years old now, on 60 patients. He used a type of citrate that's not maybe the most widespread use, at least not in Europe. There's acid citrate dextrose, ACD. There's ACD-A or ACD-B. So with this setting, he did different sampling at different level of the circuit. And what he found is that the delivery of citrate was similar whether you use CVVH or CVVHDF, and it was significant because it was 26 millimoles per hour, which corresponds to about 360 calories on a daily basis. And in addition, because lactate and glucose are also associated with calories, the total load was actually more than almost 1,300, which is really massive. So this is something that needs to be considered. Another study from the US did the same and showed slightly different results. They found a delivery of citrate of 220 kilocalories per day. So I think the message here is all protocols are different. All protocols are going to lead to a different intake, but certainly citrate is a source of calories. The most protocols, and these are calculations that I make myself, so it's not, don't take it for granted, but it's probably in this range. It's in between 150 and 300 kilocalories, sorry for the typo, per day. And if you use ACD-A, or if you have a pre and post dilution that would use lactate or other glucose solution, you have to consider this other replacement fluid that also bring some calories into your patients. So that brings me to my conclusions. So I think we discussed the fact that citrate protocols who should target calcium levels within the physiological range in order to avoid PTH rise and therefore bone resorption. It is now acknowledged that citrate improves filter biocompatibility but not influence systemic inflammation. And finally, it should be considered it should be recognized as a source of energy that need to be accounted when you assess the total caloric intake for your patient. Thank you very much.
So thank you for this nice presentation and this good overview. So there are some questions about how we should replace calcium. So should you give it in bolus, or can you give it in infusion, or do you give it on your machine, or?
So I don't know of any protocol that suggests bolus infusion of calcium. There is a continuous loss, and that can be predicted by the calculation of the protocol based on the characteristic of the filter, the blood flow, and the effluent flow. So you know how much calcium. So it's much more recommended to use a continuous infusion. Of course, then you need to measure the systemic value and the measurement in your patient, and then you can add some bolus. So it's probably more boluses to compensate. So I would say the main response is continuous infusion plus boluses as required.
And you do it on a machine, like you increase the calcium compensation, or you just give it separately?
Yeah, so that depends on the system. Some system would include directly the calcium compensation, and some would use a separate aspect. But it's always easier when it's managed by the device, because as we've shown, the calcium removal is proportional to the effluent flow. So if you, for any reason, will increase your dialysate flow, decrease your dialysate flow, or your setting of your device, then if it's all embedded in the prescription within the machine, then obviously this will be followed, and this will be more automatic. So this is a safer. I would say in general, this is one of the recent development with citrate, is that the devices now include all these elements, so they will facilitate your prescription by coupling the the citrate with the blood flow and coupling the calcium infusion with the effluent flow.
Okay, so there was also a question about magnesium. So it's a bit similar to calcium, I think, that it gets lost. But are there any data how to substitute, or?
Yeah, so it's true that of course citrate is has a very high affinity for divalent ions, so calcium, but also magnesium to some degree. It will remove calcium from the patients. The significance of hypomagnesemia is less understood. I mean, I think there's some data suggesting that it decreases renal recovery in the long term in patients, but certainly it's not as acute and as dangerous as hypocalcemia. And certainly we should monitor magnesium levels at least once a day, I would suggest. And then, yes, some protocols consider substitution of magnesium in addition to the calcium, while some include the magnesium in the solutions, so in the dialysate. So again, it depends on the protocol that you use, and I really agree with what Alex said in the previous presentation, is that if you are new to citrate, follow the protocol. Most protocols are quite well written, and they usually will take care of these issues for you.
Okay, so there's also an interesting question on a patient with hypercalcemia. So how do you manage? Do you increase the citrate dose, and do you reduce the compensation, or? So
hyper or hypo?
Hyper.
Hyper. Increase. So yeah, that's when you have multiple myeloma patients or something, that can be quite tricky to start the therapy. So you need to achieve the ionized calcium, the post-filter ionized calcium, which might require a higher dose, indeed, of calcium of a blood flow. And so this can be an issue at the beginning of the therapy. For the substitution, it's complicated because you need to adapt the substitution and you will start with a very high level. This is not so easy. So this is one of the cases I would not start if I'm not super comfortable with the citrate in general. But yes, you have to adapt to these patients. The other side is the hypocalcemia, which is the question I thought you were asking. If you have hypocalcemia, then you really struggle for the very first hour, 12 or 24 hours. I really suggest to compensate the hypocalcemia with infusion, like boluses of calcium before you start, because the system is really not made to deal with these. So if you start low, you will have to replace a very high rate of calcium at the beginning, and then eventually you will shoot up and have a hypercalcemia, and then you will go up and down, and your nurses will hate it. So I suggest you compensate first.
Okay. Do we have time for one more question? Yes. So there's a question about the calorie loss in your ORT system, because now we increased by giving citrate, but do you also lose a lot of things in the effluents, like nutrients and?
Yeah, so probably we lose micronutrients for sure. The significance of that also remains to be determined. I don't think we lose glucose because normally, again, it depends on the dialysate and the substitution solution you use, but usually this is compensated, so the loss in glucose is going to be compensated. Proteins are not going to be removed by the systems. So I guess it's mostly a use of amino acid, which is we know we are losing a little bit of amino acids and nutrients and micronutrients. So zinc, all these small molecules. So this is lost, and might or might not. I'm not really a specialist of the consequences of these losses, but certainly proteins and amino acids should be at least compensated by a higher administration through the enteral nutrition. Yeah.
Okay, so further questions from the audience? No? So thank you for this, for great speakers.